I'm Anupama Gotimukula, President AAPI, and we have been doing CMEs for last 3 months, monthly at least 2 CMEs for our members. This is one of the best benefit we can give to our members. And today is a very unique day. It is World Restart a Heart Day, October 16th. And also it's a World Anesthesia Day. So there are 2 important days out of which we are only talking about the first one. So World Restart a Heart Day. As per American Heart Association, approximately 70% of cardiac arrests happen outside the hospital and 30% inside the hospital. But the mortality is so high when it happens outside the hospital. Sudden cardiac arrest could be any reasons. We are only touch basing with one topic today, but there are multiple reasons which can cause sudden cardiac arrest. But if that cardiac arrest is witnessed by your own family or a friend, so if you do bystander CPR, there is a high chance, double or triple chance of survival. So South Asians are pretty high risk for heart disease. And we are seeing Indian population especially dying in 30s and 40s, unfortunately, with sudden cardiac arrest because of coronary heart disease. So today we have 2 special guest speakers, Dr. Inas and Dr. Amit Khera, excellent, eminent speakers. And it's very, very nice to hear from them today. And I'm going to give to Amit Chakravarti, who is the CME chair. And over to you, Amit. You can introduce the speakers and moderators today. Thank you.
Thank you, Anupama. Very great. This is the third in the series of CME's talks we have. We have great speakers and great topics, which we'll continue to do for the whole year. We are actually focusing on stuff which is actually of interest to the general public, not specialty specific. And today is a great talk about which everyone, irrespective of what specialty you are, everyone should be aware of what are the recent advances in South Asian heart disease. We are all South Asians, and you know that there's we are in the higher risk bracket of heart disease, and this is such an educational and informative talk. I can't wait to hear these learned speakers. So before I turn it over to the moderator, let me introduce my good friend, Dr. Brahma Sharma. I know him. He's a very active member in API, and I know him for the last, I would say 25 to 30 years, when I used to make frequent trips to Pittsburgh, and I know him since that time, very dear friend of mine, and it gives me great pleasure to introduce him as a moderator of today's talk. Dr. Sharma is actually currently the senior faculty in the Division of Cardiovascular Disease at University of Pittsburgh, affiliated VA Medical Center. He has been the ex-chairman of API Charitable Foundation, which is a charitable wing, and does great job for clinics in India and here. And he also was a co-chair for several global health summits in India and here. He is API chair of South Asian Heart Disease and also leads API American Heart Association Liaison Committee for Prevention of Cardiovascular Death and Stroke. So, I couldn't think of a better moderator for this amazing talk, which we're going to hear. And I would ask Brahma to take over and introduce his panel. And we can get started. Thank you.
Thank you, Amit, and thank you, Anupama, our president. This year, am I audible?
You are, yes.
Okay, so keeping in the theme of South Asian heart disease, which is a burning topic, a silent pandemic going in parallel with the COVID. As you all know, COVID and cardiovascular disease is the lethal combination. So I'm so grateful to the API leadership to take up this project this year and for subsequent years, so we can highlight, educate, inform, and enlighten our South Asian physician community and public in general. So that, let me introduce our first speaker, Dr. Inas. Dr. Inas is very well known to us here and in India. He did his medical degree from Calicut Medical School and his cardiology fellowship in Cook County, Chicago. He is a true pioneer. He's the first person, if I could remember among few, to sound the alarm of heart disease in Indians in 70s and 80s, my God. He has been doing this for the last almost 45 to 50 years. He has been a convener and a chair of multiple sessions on heart disease in ACC in India, and he has authored so many books and chapters, I cannot even count them. He has given over 1,000 lectures on Indian heart disease, almost in every city in USA. He has come to Pittsburgh. I had the honor of introducing and hosting him, as well as in India. He's a legend. His name is known. You put his name on the calendar, you will have thousands of people attending its conference, and question answer sessions last for hours and hours. So basically, he's a living legend, and his life is a message. He has been researching, talking, writing, speaking about heart disease for over a long, long time. And we are so privileged to have him today to give us a real perspective how this whole thing started. He's like an encyclopedia of heart disease, if I can use that word. And I'm so honored because he was my mentor in American Heart Association, also in GAPI and GSS summits in India. Actually, he and me and some other people wrote the guidelines for the first time. Anyway, Dr. Ines, so humbled and so proud and pleased to have you on this session. Please start. Thank you.
Thank you so much for that very kind and generous introduction, and for the invitation to present South Asian heart disease, history, magnitude, factors, and mitigation. Can you hear me well?
Yes.
I have no financial relationship to disclose. Let's start off with the learning objectives. After attending this program, the participants would be able to comprehend the history and magnitude of CAD, it's coronary artery disease, in South Asians, especially deaths under the age of 50 years. Understand that established risk factors like smoking, blood pressure, cholesterol, and diabetes do not explain this heightened risk in South Asians. Appreciate the crucial role of lipoprotein little a. Apply the importance and relevance and practical applications of South Asian ethnicity and elevated Lp(a) as an ASCVD risk enhancing factors. And finally, expansive use of statin therapy for large swaths of South Asians. So for practical purpose, I'm going to present the data under 3 subheadings, beginning with history and magnitude of the burden of CAD. These are my early seminal observations on malignant CAD in young Indians, which was the catalyst for my dedicating my life to unraveling the enigma and mitigating the risk among Indians, which is applicable to South Asians. But it all started as when I was a first-year resident. I had a fellow intern from a hospital next to ours coming to the hospital emergency room 3 days in a row. And 4th day, he was hospitalized with a heart attack and died 15 years later, awaiting a transplant. Soon after that, somebody who was working with me in the CCU, I handed over my call to him, and he had an MI. While working in the CCU, I had to go back and take his call. Then I had at PC, had an acute MI at age 37, and I will show you his coronary angiogram soon. And he developed heart failure at the age of 47, and due to malignant heart disease masquerading as small coronary arteries. I had a patient, or actually a friend, who became a patient who had a first MI at age 39, and he had advanced inoperable heart disease and died within 5 years. There was another person, a GI man, who had bypass surgery at age 44, followed by massive MI at age 55, resulting in permanent disability. I had to go to Pittsburgh, of all the places, to evaluate a friend of mine who had massive AMI, acute MI at age 46, and he was told that he will need a transplant. I went there and advised against it. These were all young, mostly young Indian doctors, 5 or 10 years in the US, all in Chicago. Then came a vegetarian professor, pathology professor with a picture-perfect lifestyle, and he was a visitor to Chicago. He was only 7 days in the US when he had not 1, but 2 AMI and emergency quadruple bypass surgery. Here is the angiogram of my friend at age 37, the large arteries. You can drive a truck through the arteries, ejection fraction 60. Now this is 10 years later. He had malignant heart disease and masquerading as small coronary arteries, ejection fraction 25%. This was the totally occluding plaque removed en masse from the right coronary artery of a person who had picture-perfect lifestyle and no risk factors. But his problem was he has left main disease and left anterior descending artery and completely filling right coronary artery. By the time we did this angiogram, he was not able to eat or even speak. This led to my description of malignant CAD in Indians and define its cardinal features. What are they? Extreme prematurity, I showed you. Extreme severity, I showed you. High mortality at a young age, I showed you. And it's a major contributor to death, CAD death, and I use the term CAD and heart disease interchangeably under 50 years of age. I thought the information was so compelling that the time has come to address this issue, and I wrote this paper, Immigrant Indian Males, Sitting Ducks for Heart Attacks, a Cause for Alarm, and called for action on March 1990. But it was not well received. When I wrote this, most of my friends, and especially cardiologists and cardiology professors, challenged and said that heart disease is heart disease. It is no different among Indians than other people, but I did not yield to them. So I wanted to do a study. At that time, my exposure was just Chicago, and all my patients were in Chicago, and most of the patients were, all of them, except one, were from Kerala. So I met with Jeremiah Stamler, the doyen of preventive cardiology, going strong at 70 then, and going strong by his own lifestyle as a living proof of his lifestyle, going strong at 100 now. He gave me the advice and logistics to conduct the CAD study on members of API attending the 1990 convention in Chicago. So he told me I need to do some literature research, which was difficult before the internet era, and came across this paper showing that, yes, South Asians had more heart disease death. Age standardized death rate among whites was 100, with South Asians having 136. But between the ages of 30 and 39, it was 210, and between the ages of 20 and 29, the death rate was 313, or 3 times. So I thought that I was not imagining that it's a real phenomenon happening. And then I reviewed the literature and found that wherever there are large Indian populations, they've had higher death rates. In Canada, 3 times higher than Chinese. In England, 3 times higher than blacks. In Singapore, 4 times higher than Chinese. And in South Africa, 30 times. And I repeat, 30 times higher than blacks in South Africa. This led to the CAD study with a $25,000 grant from API, and I raised about $300,000 to conduct the study, which showed a 4-fold higher rate of prevalence of heart disease, 90% of them angiographically documented, compared to the Framingham Offspring Study 2.5. No difference between vegetarians and non-vegetarians, and rates were similar to the rates in New Delhi and Chennai. But Kerala and Goa, 2 states in India considered the coconut capital of the world, had even higher rates. Now I'm going to challenge some of the conventional wisdom and thinking. This is data from the Institute of Health Metrics website. And this is a study, startling information, both actually China, India, and US. All 3 countries had nearly identical number of CAD deaths in 1990. By 2001, China overtook India and both increased death rates, but US did not have any increase. Now, that perception that 24% of the South Asians have 60% of the cardiovascular disease is disproved by this slide, because India accounts for 75% of the South Asian population, and the major cardiovascular disease spectrum among South Asians is coronary artery disease. Actually, 57% of the cardiovascular disease among South Asians is coronary artery disease, in contradistinction to other Asians, such as East Asians or China and Southeast Asians. Their predominant form of cardiovascular disease is stroke. So we South Asians share the cardiovascular disease spectrum of Americans, Europeans, and Canadians. So if you look at that slide, the problem is mostly for the Chinese. Now I am going to show you data on CAD death rates, age 50 to 69, technically premature heart disease. India, substantially higher and increasing further. China, in spite of having higher death rate overall, is low and is plateauing. So we have a big problem with the premature heart disease. Now, this I specifically looked and put it here because we have talked to our president, who is very concerned about extremely young Indians dying from heart disease. We don't think about heart disease in women or even men under the age of 50, let alone die from heart disease. Here we are seeing here the data. India, 185,000 people dying under the age of 50. China, 88,000. USA, only 15,000. So here we have a very major problem with extreme prematurity. So the question is, our topic also is today is South Asians. How does South Asians compare with India? As I mentioned, India accounts for 75% of the South Asian population. And overall, South Asia accounts for 24% of the world population and 20% of all deaths and all death at all ages, or CAD death at all ages, but 34% of CAD death between the ages of 50 and 69, and 38% of CAD death under the age of 50, driven mostly by Indians. For comparison, only 2% of the death under the age of 50 in the US, only 2%, and world average is 8.4% for death and CAD death under the age of 50, and 23 for age 50 to 69. Again, I'm going to show you even more startling data. South Asians, total number of deaths under the age of 50 men 165,621 women here, but women, South Asian women, premenopausal women, non-smoking, they account for 41% of the CAD death in the world under the age of 50, and even higher than what is reported for men, which is 37%. Again, driven mostly by Indians. For comparison, only 9% of all CAD deaths in the world is under the age of 50 in men and only 4% in women. So South Asian mortality under the age of 50 is 10 times higher than the world average. Many of you have seen this article, and about 500 people responded to this article, and I am going to give the answer to this question in the next 15 minutes. So I told you earlier about the CAD study, started with the seed money from API. And we looked at the risk factors in about, and we had comparative data from the Framingham on 580 people, including the lipid profile. Smoking and obesity were extremely low, less than 5%. The lipid profile and blood pressure and all other risk factors were similar or lower among Indians than whites, with the exception of diabetes, which was 9% then and 18% now. So there are a lot of studies happening now in the UK, and this is by far the largest epidemiological study involving nearly 17,000 white men, South Asian men and women, and 7,000 whites. And some interesting data coming up, adjusted for the age, gender, smoking, cholesterol, diabetes, hypertension, obesity, abdominal obesity, insulin resistance, triglycerides, and HDL. Anything and everything you can think of, they have adjusted and reported that 81% higher prevalence of diabetes. A previous study has shown that 2.24 higher risk of mortality, but that was only 3,000 people. This is a slide taken from the paper by our next speaker, Dr. Khera, showing, and this is one of the most important slides. This is from the London, UK Biobank study. South Asians compared to whites over a period of 12 years had double the incidence of cardiovascular disease, double. But this would have been even higher if they looked just coronary artery disease, because for South Asians, coronary artery disease is much more important, but 3 times larger involvement than stroke. But when we use the pooled cohort equation, which is used to predict the risk and prescribe the statin therapy, there was no difference between South Asians and whites. And when they used the Q-risk3, similar observation. So this solidified the previous data, which I have been saying for the last 20 years. South Asians are double the risk of CAD, which is not predicted by the ASCVD risk enhancing factors. So is diabetes the major player? Many people think so. I am the first person to challenge diabetes as the major contributor, which is anyway 3 to 4 times more common than in South Asian than whites. It occurs at a younger age and at a lower BMI, associated with the greater risk of CAD and complications, and yet diabetes and other metabolic risk factors explain only a third of the excess burden of CAD based on a 22-year follow-up of a study in the UK. So we have a problem of South Asian enigma, established risk factors, as well as other lesser known factors such as insulin resistance, metabolic syndrome, and low socioeconomic status all fail to account for the twofold risk of heart disease in South Asians. So what is causing this problem? We have written, it took about 2 years for me to write these two papers, lipoprotein little a, an independent genetic and causal factor for cardiovascular disease and acute myocardial infarction in all papers. There's about 500 references. And second paper focused exclusively on Indians. Lipoprotein little a, an under-recognized genetic risk factor for malignant CAD in young Indians. And my last author is the chief of cardiology at All India Institute of Medical Science. And he told me that, Ines, it seems like you have unraveled the enigma. So what is the relationship between Lp(a) and CAD? It's an independent causal factor with a twofold risk, similar to other established risk factors. Smoking, blood pressure, cholesterol, diabetes, all of them confer a twofold risk, but Lp(a) has also twofold risk, but it doubles the risk on top of the established risk factors. Unlike all other risk factors we are familiar with, Lp(a) levels are determined almost entirely by genetics at the time of conception. And it is a major determinant of residual risk and extremely premature CAD, clearly demonstrated in the Jupiter study by Dr. Kera. And now let's look at, let me see one, okay. The levels, LPL levels are, these are nanomoles per liter, and you can divide this by 2.15, you get the milligram per deciliter. The levels vary fourfold. Chinese having the lowest, blacks having the highest, white is the standard. So South Asians have 60% higher LPA level and double the level of Chinese. And remember, I told you that the levels parallel the CAD risk observed in that country for the last 60 years. Women, especially postmenopausal, have higher LPA levels, and people with the CAD have higher levels of LPA. So let's look at LPA level in South Asians and Indians. LPA level more than 50 milligram is found in 20% of the whites, 25% of the South Asians, and 30% of the blacks. And levels in the cord blood parallel the CAD differences, and stable lifelong levels reached by 2 to 5 years of age. So by the time you celebrate the 5th birthday, those who have high LPA, the arteries have already started plugging. And the CAD risk is highest in people under the age of 50. So now, malignant CAD has 4 characteristic features. Okay, malignant CAD in young Indians: extreme prematurity, extreme severity, high death rate at a young age, and high prevalence at a young age. Elevated lipoprotein share all 4 features. None of the other risk factors, including familial hypercholesterolemia, do not share all these features. FH shares, but its prevalence is only 3 or 4 per thousand. Again, I want to make a comparison with the diabetes, which we all understand. Diabetes affects 415 million people globally and 2.45 billion globally for lipoprotein a if we take 30 milligram at the cut point. If you take a more conservative cut point of 50 milligram, still it is 3 times higher than diabetes globally. How about South Asians? Diabetes, 78% have diabetes, but 25% have elevated LPA. And if you take 20 milligram, that is usually the threshold found in India. 44% have high LPA compared to 7 to 8% having diabetes, and the CAD risk is near identical. CAD risk in epidemiological studies is 2-fold, and genetic studies is 3-fold. It's comparable to diabetes. So I was talking with my friend and guru Salim Yusuf for many years to look at the lipoprotein a in the inner heart study, and here is the data. in the diabetes, the odds ratio for CAD was 2.52 and population attributable risk was 12%. Lipoprotein little a, the PIR was very similar, just trailing, and odds ratio was similar. But in this study, and as most epidemiological studies are done today, nowadays, used frozen plasma stored for many years, prevalence was only 9%, much lower than 25% reported from the CAD study earlier, and lower than the NHLBI estimate. So, in my view, high lipoprotein little a robust surrogate for LPA gene to early CAD in South Asians, is analogous to BRCA gene for early breast cancer. Besides, the heightened risk and burden of AMI from elevated LPA in South Asians is analogous to the heightened risk and burden of stroke from hypertension in Blacks and African Americans. Having said this, what are the professional gaps? The twofold higher risk of CAD at given level of established risk factors remains largely unrecognized by the medical practitioners, including Indians and South Asians. Although 25% of the South Asians have elevated LPA-little a, 99% of them remain undiagnosed and unmanaged. And another point, is very important point, those who had LPA-little a cholesterol measured by vertical autoprofile or VAP should have the LPA protein measured using an accurate assay method. The method was proven to be inaccurate, and the company also declared bankruptcy. So the first question comes up, who should have the LPA measured and when we should measure the LPA-little a? My task is made easy by the 2021 Canadian guidelines, which recommend universal screening for elevated LPA-little a once in a patient's lifetime, and do it as part of initial lipid screening to assess the cardiovascular risk. They were so convinced, and I am going to quote their reason for recommending that. The high prevalence of elevated LPA-little a level, the strength of association with incident and recurrent ASCVD events, and the potential to improve severe risk stratification strongly justify universal screening to identify individuals with very high levels. Previously, the European guidelines have recommended once in a lifetime measurement, but Canadian guidelines went one step further and said, do it along with the first measurement. And they further recommended coronary artery calcium score in people with elevated LPA-little a to identify the people who benefit the most from the CAC score. CAC score provides predictive information over and beyond the ASCVD risk calculators because it's integrate the effect of all measured and unmeasured risk factors over the course of an individual's lifetime up until the point of CAC measurement, and by far the best non-invasive measure of atherosclerotic burden in the coronary arteries. A CAC score of more than 0 establishes or confirms the presence of atherosclerotic plaque. What does the plaque numbers mean? More than 0 means plaque has started and it is reasonable to start statin therapy, and more than 100, it's necessary to start statin therapy. More than 400, you have to use high intensity statin therapy and throw everything you can throw at, because it is a CAD risk equivalent. More than 1,000, the risk increased 11 to 16 times. No other risk factors, no other ASCVD risk predictor can predict this gradient of risk from 0 to 100. So the next question is, should we use statin therapy in people with a calcium score 0? Generally, the answer is no, with 4 exceptions. Which are they? Those with a family history of premature CVD, those who are smokers, diabetics, and poorly controlled hypertension, those who are LPLA or familiar hypercholesterolemia, and those younger than 50 years of age, most likely they are likely to have plaque but not calcified. So usually when I come to this stage, most people ask me, so you mean to say that all we have to worry about is lipoprotein little a? No, that's exactly not what I am saying. Lipoprotein or nature explain 30%, 20 to 30% of heart disease, but genetics loads the gun and environment to pull the trigger. And what are the triggers? Established risk factors like tobacco, high cholesterol, hypertension, risk enhancing factors, including metabolic syndrome, triglyceride, LPLA. Then LDL particles among South Asians are highly enriched with ApoB and LPLA. Then of course we have the high diet enriched with saturated fat, fried food, and air pollution second only to cholesterol in India. Then total absence of primordial prevention and near total absence of primary prevention, poor awareness, treatment, and control of the risk factors. And last one, I'm almost embarrassed to say, low quality of CV care, cardiovascular care, before, during, and after an acute myocardial infarction. This again coming from the Dr. Khera's study, showing that from high levels of LPLA is associated with approximately twofold risk of CAD. So people ask me that if lipoprotein little a is such an important factor, how come it did not create much problem or epidemic 30 or 40 or 50 years ago? The answer is in this slide, but somewhat difficult to explain. This data is taken from the EPIC Norfolk cohort, 6-year follow-up, CAD only. And here, this is the Framingham risk score, low, less than 10%, 10 to 20%, Framingham risk score more than 20%. They took LPLA tertiles, low tertile 7.25 and high tertile 11.69. It's a very low LPL levels. And yet, now let us look at the risk. People who had low Framingham risk score and low LPLA, the CAD risk was 1. But when you had high LPLA on top of low Framingham risk score, the risk increased only from 1 to 1.6. Now look at here, Framingham risk score increased to 20. LPLA jumped the risk from 2.4 to 4.5 or from 1.6 to 4.5. So LPLA is fully capable of magnifying the risk 2 to 3-fold on top of established risk factors. Now, the last segment of my presentation, mitigating the risk. Usual answer to this question is that nothing can be done. That's absolutely not correct. So in the United States and in India, over the last 30 or 40 years, the obesity doubled and diabetes doubled. But in the US, age standardized mortality came down by 55%. And how to communicate this to the people? They have developed, the American Heart Association has developed the ideal cardiovascular health as conveyed as life symbol 7 for symbol 7. And I have modified it to life symbol 7 for Indians, but let's look at the life symbol 7 for Americans. Not smoking, exercising regularly, healthy diet, maintaining BMI less than 25, blood pressure less than 120/80, blood sugar less than 100, and cholesterol less than 200. I agree with all that, except Indians or South Asians need more exercise, and ideal cholesterol among Indians should be less than 140. I will explain to you in just a moment. So 25 years ago, Cardio Research has proposed South Asian ethnicity and LPLA as ASCVD risk enhancing factors. Now, the ACC AHA guidelines have formalized these two along with family history of premature CAD, high LPLA, high triglyceride, metabolic syndrome, premature menopause, pregnancy complications, all included in the list. So what is the importance of this? all South Asians have at least one risk-enhancing factors, and many of us have multiple risk factors requiring statin therapy unless the LDL is already less than 70 or CAC score is is 0. So why statin therapy? Statin therapy is no longer limited to those with elevated LDL. It is indicated to reduce the ASCVD risk in people from any risk factor, and it lowered the risk without lowering the LPL, whereas PCSK9 inhibitors inhibit lower LDL and LPL. And the totality of the data now suggests that LDL more than 70 milligram leads to both vulnerable plaques and vulnerable patients, and I must add, vulnerable South Asians and vulnerable Indians. American guidelines have already lowered LDL threshold for statin therapy from 100 to 70 mg/dL. The GBD study uses global burden of study by the Institute of Health Metrics now uses optimum LDL as between 27 and 47 mg/dL. Among the LDL lowering reduces the ASCVD events proportional to the absolute reduction in LDL-C and the cumulative duration of exposure to lower LDL-C. Higher dose statin, which reduce the LDL more, gives greater ASCVD benefit. And for very high risk ASCVD patients, the Lipid Association of India now recommends LDL 30 milligram. And I repeat, LDL 30 milligram is recommended by the Lipid Association of India for people with very high risk people, such as South Asian with heart disease and diabetes or LPL. And the European guidelines has lowered it to 55. And American guidelines recommend statin therapy and intensive statin therapy and do not recommend reducing the dose unless the LDL is less than 25 2 times 4 weeks apart. Atorvastatin and rosuvastatin are approved for children as young as 10. When it comes to statin therapy, in spite of all this knowledge, statin therapy is generally too little, too late for South Asians. So now we discuss the importance of statin therapy as a ASCVD risk reduction strategy, not just as an LDL lowering therapy. But when should we lower the LDL? So this is a very provocative data. Genetic polymorphism result in lifelong reduction in LDL-C by 40 milligram is associated with a 55% reduction in CAD risk, in contrast to a 20 to 25% reduction with the statin therapy middle at ages 50 or 60. So 55% if you start early or lifelong. This has now just been tested in an outcome trial. Nearly 500,000 people presented in a European Society meeting just last week. The gist of the information is that if you lower LDL at age 60, you reduce the events by 27%. But if you lower the LDL at age 30, you reduce the risk by 52%, almost identical to those happening with lifelong reduction in LDL-C. So we should use statin, but the statin therapy is, except in people with a known heart disease, is recommended for people with high 10-year risk, 10% risk in the UK and Europe, and 7.5% risk over the next 10 years. But in India, again, I am embarrassed to say that cardiologists do not use any of the risk prediction models, probably because they see around 250 to 300 patients a day. Don't ask me why and how. So I have written an invited editorial simplifying statin therapy for Indians. For this is order of strength of recommendation, highly recommended, reasonable, and may be considered. They recommend people with established risk factors on a statin therapy without even measuring the cholesterol. And if you measured it, cholesterol 170 should be sufficient to start statin therapy. We should consider starting therapy for Indians with who already have one risk-enhancing factors plus one more risk-enhancing factors like LP-Little-A or triglyceride. And finally, consideration should be given for starting statin therapy in men at age 40 and women over the age of 45. After showing the data, I think I'm beginning to think that maybe we should lower the age for women also to 40. Now, last 2 or 3 slides. Polypill is coming big time, and my good friend Salim Yusuf has just published a meta-analysis of 3 polypill studies. Polypill is a single formulation of fixed combination treatment, 2 blood pressure medications at the half dose, a statin and an aspirin. Meta-analysis showed that there were 721 primary outcome events, well tolerated with only small insignificant excess GI bleed, in sharp contrast to when aspirin was used alone in primary prevention. And what did they find? Polypill with aspirin cut down the ASCVD risk by 47%. 47%. N and D was 37, but without aspirin, only 37% reduction. South Asians account for 38% of the global CAD death under the age of 50 years of age. 90% of the Indians have suboptimal blood pressure, more than 120. Poor control of the blood pressure, 20%, only 20% of the urban Indians and 10% of the over Indians have their blood pressure controlled below 140/80. Dismally low statin use, 5% in both primary and secondary prevention. And this is brand new data, just came in last week. 77 million Indians have diabetes, of which 42 million or 58% are undiagnosed. How about those who are diagnosed and treated? A1C more than 7% in 74%, with a mean A1C of 8.56. Fasting blood sugar is 172. So what we are seeing in India is natural history of the epidemiology of coronary artery disease, not interfered with much. So what have we learned today? This is my last slide. South Asians have double the risk of CAD, even when adjusted for established risk factors, and the pooled cohort equations and Curious 3 do not explain the risk or do not predict this risk. And so anyone using this, you should lower the threshold from 7.5 to 5% or 3%. South Asians are one of the highest risk populations, accounting for 24% of the global population, but 34% of the global CAD death under the age of 50 to 69. And yes, 38% of the global CAD death at ages 50 years, under 50 years. Lifelong exposure to LP-Little-A, beginning with the 2 to 5 years of age, found in 25 to 44% of Indians, plays a crucial role in malignant CAD, which drives the extremely premature CAD death in South Asians. LPA should be measured as part of the initial lipid screening to assess the CVD risk. I couldn't agree more with Canadian guidelines, who are not really very aggressive people. If I am to recommend 2 or 3 tests for South Asians, number 1 will be lipoprotein Little-A. Number 2 will be, and that is you do it only once in lifetime. If you have the question about the accuracy, repeat once more, never repeat unless and until treatment is available. By the way, the outcome trial is currently underway and will be published by 2015. Then If you have high lipoprotein little a, you should measure calcium score. It will help you. And the third one, the cholesterol levels and lipid panel level, if you look, it's more favorable than Indian just came yesterday. But ApoB is substantially higher among Indians. So ApoB, Lp(a), calcium score, these three tests can help guide your statin therapy along with life symbol 7 for Indians. Statin therapy is recommended for those with elevated ASCVD risk, including those due to high Lp(a) and or established risk factors. Life symbol 7 for Indians should be adopted early for all South Asians, and expansive statin therapy and possibly polypill seems appropriate for a very large swath of population of South Asia. A lot more information is available in my website, and I'm sure there will be a lot of questions after the second speaker. Thank you very much, and giving me, I thank Happy and our president for giving me the opportunity to make this presentation. And by the way, a very abbreviated summary of this talk will be appearing in the next issue of the Happy Journal. Thank you.
Thank you, Dr. Innes. I think before we go to the next speaker, there are some burning questions, and I think we'll address some questions and answers for the next maybe 10 minutes or so. And
I'd love to do that.
And if there are anything left over, then we'll address them after the talk is over.
Wonderful.
After the second talk. So let's get Dr. Sharma to go ahead and ask the first question. He and I will kind of alternate and we'll ask questions which are posted in the chat box. Dr. Sharma?
Yeah, Dr. Innes, that was great presentation, a very excellent overview, and also up to date. So a lot of questions are coming, but most of the questions are on Lp(a), which is your expertise. So I want to combine some of these questions into one long question, and if you can address those, that would be appreciated. And the question is, what is better, a CAC scoring, calcium, coronary calcium scoring versus LPA? And LPA is a modifiable, is a marker or mediator, and how to bring it down? I know the statins don't do anything about it. What is your current therapy for lowering the LPA? Dr. Innes.
Thank you so much for that question. Calcium score tells you whether you have developed the heart disease already. Calcium score more than 0 tell you the atherosclerosis has begun. It won't tell you why, and you don't repeat that. So when people are doubting about whether to go on statin therapy, calcium score help you modify the treatment. Lipoprotein little a is not a marker. It is not a risk factor. It is only, there are only 2 causal factors. Framingham discovered risk factors. Risk factors do not cause, they are risk factors. Lipoprotein little a, genetic studies have shown it's a causal factor. It has so much predictive power. So LP little a tells you whether when you are going to have heart disease or how risky you are, and LP little a, CAC score tell you whether you have already developed the heart disease. Now, the third question is more important. The mitigating the risk. Currently, there is no agent to lower LP little a, and lifestyle modification also doesn't affect. But the LP little a risk is modified or doubled by established risk factors. So most aggressive treatment of smoking, blood pressure, cholesterol, and also most aggressive, I did not get a chance to explain the life symbol 7, because we need to pay attention to more our waist circumferences, more 90 centimeter for men and 80 centimeter for women. And also we need more exercise. We have to be careful about the excess intake of saturated fat. In India, trans fat probably half the world's trans fat is consumed by Indians because Vanaspati is up to 50% trans fat. So we do all the 7 things, life symbol 7 for Americans, modified to South Asians or Indians, and yearly starting of statin therapy. And by the way, this gives me an opportunity to explain the angiogram I showed and the angiogram I used to write up the paper, Malignant Heart Disease in Young Indians. My friend, who is still with us, 37 years ago, he had an MI. His father had MI at 37, and he did get an MI at 37, and his father died at 45, but my friend had malignant heart disease. I measured the Lp(a) on his son. He had identical level 127, both father and son. I put him on statin therapy at age 11, and we measured a calcium score 30 years later on him. And with the sky-high calciums, the Lp(a), we were able to prevent from his developing atherosclerotic plaque. So what I did to the 10-year-old son of my star patient is what I recommend.
Okay, thank you so much, Dr. Ennis. I think we have time for a couple more questions. I'll ask something which is not strictly related to the therapy part of it. There's a general question which says that you have always mentioned that high death rate for cardiovascular disease for South Asians. Someone has asked that there is less cardiovascular death rate in Pakistani and Bangladeshis compared to Indians. Do you have any insights on that?
Yes, I am privy to some unpublished data. I cannot say quote the data. There are so many prospective studies going on, and there are studies done in the UK showing that the heart disease risk in the UK is 30% higher. In fact, the QRISK-3 uses the calibration factor of 1.3 for Indians, 1.5 for Pakistan, and 1.7 for Bangladesh. Almost all the studies show that Pakistan has higher risk of heart disease than Indians, and Bangladeshis have even higher risk. So, but the data on Pakistanis and Bangladeshis is very, very limited. We have much more data on the Indians, and Indians comprise 75% of the population in South Asia and 85% of the South Asian population in the US. Yes, so if at all, Bangladesh is at the highest. There are some contradictory data. Pakistan or Bangladesh is at the highest, but both are worse than Indians.
Wow, so that's great to know, because that's what. So Brahma, do you have maybe a couple more questions, or maybe one more question?
In the interest of time, we have only a few minutes left before we invite Dr. Khera. Dr. Ennis, can you just give a brief rundown as to which therapies work for LPA? There's some questions whether statins, PCSK9, Nexletol or niacin. The Nexletol is a new therapy that is on the horizon. Can you tell us any?
They also asked about Repatha and Prevalent.
Okay, so let me, if you have more time. I used to use niacin lowers Lp(a) by 40%, but it's not available, no outcome studies, so it has become obsolete. Even if you want to use it, it's not available, and there's no data. 2 outcome trials failed it. Statins lowers the risk from elevated Lp(a) without lowering the LDL. This was shown in the Jupiter study. The statins lowered the risk in people with and without lipoprotein delta. And so my strategy is to use aggressive high-intensity statin therapy and knock down the LDL as much as I can. But people with very high LDL may not come down because most of their LDL is enriched with the LPA. The Repatha and Prevalence both actually the Canadian guidelines have recommended that using like the PCSK9 inhibitors do lower LDL significantly and do lower Lp(a) by 25 to 30%. And there is some preliminary data suggesting that the PCSK9 inhibitor, Repatha and Parulin, lower CVD risk independent of LDL also, but it has not received approval from FDA. The other medications are only theoretical interest that's not used because it's so expensive, many of the medications. Now, there is some oligonucleotides have been discovered and used and shown to lower the Lp(a) by 80 to 90%. And currently, there is a study called Horizon trial. It's already started 2 years in the making now, and results are expected by 2024 or 2015. And that is an injection, lowers the Lp(a) by 80, 90%. But don't count on that. It is also going to be $1,000 a month injection shot. So we need to do maximum lifestyle modification, start statin therapy, and hope that this the Horizon trial is positive. And I don't use any of the other lipid agents because they are all very expensive and most of the insurance do not cover.
Okay, thank you very much, Dr. Ines. Now, let me invite Dr. Khera, Amit Khera. Dr. Amit Khera is a new rising star in the preventive cardiology. He's an epidemiologist, he's a geneticist, and just to go over briefly, he did undergraduate from UPenn and medical degree from Baylor College of Medicine. He did internal medicine residency from Brigham and Women's Hospital, fellowship at University of Texas. He also did his MBA in public health. And currently he is an associate director at the Precision Medicine Center of Genomic Medicine at Mass General Hospital, also associate director of cardiovascular disease at Broad Institute, very prestigious institute at MIT and Harvard. And he's been a teacher and researcher and so many publication chapters, and I don't want to go into detail, but his latest gig is genetic prediction for South Asian. He is developing and developed already a genomic score for South Asians, and that is catching everybody's attention all over the world. We are so pleased and honored to have Dr. Amit Khera to spend some time with us today to enlighten us on this nuances and cutting edge technology and genomics on South Asians. Amit.
Hello, and thank you so much for having me today. And this is a fantastic first talk by Dr. Ines, where I learned a lot as well. And today, as you say, I want to discuss a topic that's very close to all of our hearts and really saying, why are the rates of cardiovascular disease so high in South Asians? And is it the genetics or is it actually the jalebi? And this is a question that we discuss around my family dinner table on almost a weekly basis. But as you say, I'm a cardiologist. I lead a research group at Mass General Hospital and the Broad Institute here in Boston. And really our goal is to largely use genetics as a tool to really try to understand biology of different cardiovascular diseases. So we recently did a study, looking back over the decades, people have thought that South Asians appear to be of much higher risk for cardiovascular disease. And in the US guidelines, as we learned, it's actually the only ethnicity that's singled out as a risk enhancing factor. So they say, we don't know how much the risk is increased, but if you have a South Asian patient, they encourage all doctors to increase the risk in their head. And we set out to say, okay, well, is that actually true even now in contemporary clinical practice? Because statins and cholesterol medicines and blood pressure medicines have improved so much. And here I'm showing you that, unfortunately, it is still the case. So on the horizontal axis here, I'm showing you that we followed patients, over 300,000 patients for 10 years. And on the y-axis, the vertical part, I'm saying how many of them developed heart disease. And the South Asians are the ones seen here in the red line. And you can see the red line going up much faster. In fact, their risk of heart disease was more than double that of those of European ancestry. And we then said, okay, the risk is more than double. What about the predicted risk? And here what I'm showing you is the predicted risk that the US doctors would use every day in clinical practice. And it turns out that there was no difference. So what this means is that despite the fact that the predicted risk is identical, we're suffering from disease at double the rates. And the reason for this is actually quite simple. If you go back and look at the participants that went into the study to make this equation, there were 0 South Asian individuals. We then said, okay, well, given that the risk is double, how might we try to explain this? And so here I'm showing you if you just look at overall, the hazard ratio or the risk was 2.0, so about double. And we then said, okay, what would happen if we start trying to adjust using statistics for other factors? If we adjust for high blood pressure or hypertension, for diabetes and kidney function, you can see the risk decreased a little bit from 2.0 to 1.5. So it was explained a little bit by some of these factors. We went on to do everything we could think of: obesity measures, inflammatory disease, lipoprotein A, C-reactive protein, family history. And even after we adjusted for everything we possibly could think of, there was still about a 1.45% increased risk. So what this means is that these traditional risk factors explain some of the increased risk, but there's still a lot to be uncovered and unpacked here. If you go through and look at some of the individual risk factors, we said, okay, well, which are ones that seem to play an outsized role? And some of the factors that we picked up on, as Dr. Enos mentioned, is that diabetes is really very, very common among South Asian individuals, about quadruple, 4 times as common as those of European ancestry in the study. And what was very important is that the rates of diabetes it often occurred in South Asian individuals, even in the absence of obesity, which almost never happens in European populations. Second, we noticed an increased prevalence of central adiposity. You can see in South Asian women, 47% versus only 30% of Europeans. And this is the apple shape that we talk about, where more of our fat appears to be clustered around our belly. And lastly, as we heard, we have increased concentration of lipoprotein a, which is a cousin of bad cholesterol that we already learned a lot about. In fact, the normal level in Europeans is 19, but in South Asians it's 31. In fact, if you look at all the things that are measured, biomarkers that are measured in clinical practice, it's this lipoprotein A that varies the most by ancestry, more than anything else we measure. So with this in hand, we see a very striking increase in risk. And we thought, well, what have we actually learned about the genetic drivers of this increased risk for cardiovascular disease? And the traditional approach for genetics is to focus on very rare, what we call monogenic mutations, monogenic meaning one. It's a single base pair that leads to very high risk. And the classic example for cardiology is familial hypercholesterolemia. So again, it's a single base pair. It prevents you from clearing the cholesterol from your circulation. So from the time you're born, you have very, very high levels of LDL cholesterol. And on average, this is associated with about a tripling of your risk for heart attack. And it affects about 0.4% of the population, both in European and South Asian populations. So 1 out of every 250 people actually has one of these very high risk mutations. And it's very important that we try to go out and find these people because we can't help them if we find them. But there's also a much more interesting question, which is what can genetics actually start to say about the remaining 99.6% of the world? And here we actually decided we needed a new approach. So we needed genetic prediction based not on one variant, but many variants, even millions of them. So to do this, we derived a score based on a large study. We looked at 60,000 people, some of them were South Asian, some of them were other ancestries, and 120,000 controls. And we looked at all the 6 million places where my DNA might differ from yours. And we said, which are the genetic variants, the changes in the DNA code that are more common in the people who had heart disease? And those variants are called risk variants. And also, which variants are actually more common in people who didn't have disease? Those variants actually confer a little bit of protection. And so at the end of that, we ended up with a list of 6 million rows. Some variants increased risk by 2%, some decreased risk by 1%, and so forth. We then used very sophisticated computational algorithms to combine information from all these 6 million variants into a single number. And that number is what we call a polygenic score, poly meaning many, genic meaning genetic. Here I'm showing you that number is normally distributed in the population. And we said, okay, well, does it actually matter where you are in this distribution with respect to your risk? And it turns out it did. So here I'm showing you, we looked at the score in 300,000 people. On the x-axis is the percentile of the polygenic score. And on the vertical is the chance that people developed heart disease by the time they reach middle age, in their 50s or so. And what you can see is that there's a very striking gradient, risk ranging from only 1 to about 11%, just based on common genetic variation alone. Now, the traditional approach, of course, is to say, again, compare carriers of high-risk mutation and non-carriers. So we said, what happens if you actually call the top 8% of the polygenic score distribution a carrier of a high polygenic score, and the remaining 92% non-carriers? Here's what was very surprising. The top 8% actually had greater than triple the risk. So the risk was actually equal to that of a familial hypercholesterolemia mutation, but it was 20 times as common. Now, these very high genetic risk individuals, it turns out that the traditional risk factors are not adequate to find them. So here I'm showing you just the characteristics of people with the high polygenic score versus the remainder. And you can see that family history is a little bit more common, 44% versus 35%, hypertension 32% versus 28%, and so forth. So although some traditional risk factors are slightly elevated, none are enough to be useful in picking these high-risk individuals out from a crowd. So why is that? Well, if you just look at the variants that have the strongest weight and carry the biggest effect size in the score, it turns out about 20% of them are associated with things we measure in practice: LDL or bad cholesterol, lipoprotein A, and triglyceride-rich lipoproteins. Another 20 to 30% are things we know are important or think are important, but either we don't or can't reliably measure them in practice: cellular proliferation, inflammation, and vascular tone. And lastly, it turns out that there's about half of the variants where we know beyond a shadow of a doubt they're very strongly associated with heart disease, but the reason is actually not clear. In some cases, we were actually able to identify new biology by where we could go from a variant to understanding a new pathway, but in others, we actually are not sure. But that's kind of an example of why it's that the traditional risk factors can't find these people, because it just has so many different pathways, some of which we don't even know of. So one question then comes up that as clinical practice, I mentioned in the US, we use this pooled cohorts equation. And on the y-axis here, I'm showing you the 10-year rate of heart disease. It's a study from the United Kingdom. And what you can see, for example, is those in intermediate risk, that's 7.5 to 20%. These are people who are often on the fence about starting a statin medication. And what you can see is that those with a low polygenic score, in the bottom 20%, the risk was only about 2%. Versus a high polygenic score, it was 8%. So even if you know the clinical risk estimator that we use, knowing this polygenic score is a powerful way to modify that risk that could tip you towards a medication or away from a medication. We went on to replicate that. We saw very similar results in the Malmo diet and cancer study. This is a study from Sweden. So again, regardless of what your clinical risk is, the genetic predictor is a very powerful determinant of whether or not you go on to develop heart disease. And if you actually just look at the correlation between the genetic predictor and the clinical predictor, it's almost zero. And the reason for that is actually quite simple, that the clinical risk predictor we use in practice is mostly driven by age, sex, and smoking. And none of those actually are strongly determined by genetics. So one of the important factors for genetics is that you can measure these things from the time you're born. And so we looked at young individuals, young adults aged 26 years from a study. They were followed for 30 years. And we were able to look at how does their risk for heart disease play out over those 30 years. And so here I'm showing you that after 15 years of the study, we measured their coronary calcification. And that's an early sign of heart disease, subclinical heart disease. And what you can see is that those who had the best polygenic score in the lowest quintile, the risk was only about 5%, versus the top quintile, it was about 18%. When they followed people forward over time, they measured the calcium again at year 25, so that they were about 50 on average. And you can see that the risk ranged from 21 to 45%. So you really get a sense just from this that these individuals, based on your genetics, are on a very different trajectory. And this is developing early plaque or calcium. What about having a heart attack or dying? Well, here I'm showing you that there was also an important determinant of developing a heart attack. So here on the horizontal part, I'm showing you we followed these people for 30 years. And on the Y, the vertical axis, is the chance of developing heart disease. What you can see is that for those in the lowest quintile, only about 1.5% of them went on to develop disease, versus the top quintile, it was about 12%. Now, one of the things that was new about this study is because we had the genetics and the imaging measured, we said, well, what is the interplay of them? And this was new data where we said that even if your calcium score was 0, your genetic, if you had good genetics, your rate was about 1 or 2%, versus bad genetics, it was about 4.5%. Now, if you had evidence of calcium, all the rates were much higher, but your risk ranged from 7 to 32%. So this is really one of the first examples of showing that the genetics is a powerful determinant of future risk for heart disease, even in those who we have their calcium measured, whether you do or don't have calcium. So one question often comes up, is your DNA your destiny? And is it true that if you have a very high genetic risk, that you're predestined to go on to develop heart disease? And so we set to look at that in a couple different ways. The first was related to healthy lifestyle. So we defined healthy lifestyle by some of the criteria you heard about, exercising regularly, maintaining a healthy diet pattern, avoiding smoking, and maintaining a normal weight. And what I'm showing you here is that all of these people, we follow 50,000 people, and the Y vertical axis is the chance that they develop heart disease over 10 years. And I'm showing you only those with the highest genetic risk. And what you can see is that for those with the highest genetic risk, if you had an unhealthy lifestyle, your risk was about 11%, versus a healthy lifestyle, it was only about 5%. So you were able to cut your risk by about 48% across the 3 studies, simply based on adherence to a healthy lifestyle. In fact, those who had bad genes but a good lifestyle, they got the risk about to the population average. They could never necessarily do as well as people who had good genes and a good lifestyle, but they're able to really fully offset their genetic risk and get back to normal. And this has been very helpful even in terms of how I counsel patients in my practice. Now, what about medications? Well, here I'm showing you data from clinical trials of statins. And these studies were done many years ago, but we had DNA in the freezer and nobody knew what their polygenic score was. They hadn't even been invented yet. But here again, I'm showing you just individuals with the highest polygenic score. And what you can see is that those who got a placebo or a water pill, their risk was about 20% of having a heart disease event. But if they got a statin, it was only about 12%. So again, a 40 to 50% risk reduction. And this was developing the first onset of heart disease. In fact, if you go through and look at it, this is actually one of the only subgroups who gets the greater relative and absolute benefit from statins. So this is really an enhanced benefit group for statin therapy for these high genetic risk individuals. So how might we put this all together? And can we actually think about how polygenic background and monogenic factors can come together? And so I mentioned before that the traditional approach is to think about these monogenic single bad mutations as being very high risk, like those related to familial hypercholesterolemia. And here I'm showing you just the chance of developing heart disease by age 75. And the traditional approach, as I said, 1 in 250 people has high risk. In this study, it was about 41%, versus pretty much everybody else has lower genetic risk. And the risk was about 13% in this study. But look what happens if we now model in the impact of the polygenic score. Here, what I'm showing you, the x-axis now, is the percentile of the polygenic score distribution. And what you can see in the gray dots is what I showed you previously, where there's a major difference in gradient in risk across these percentiles. But look at these blue dots. And what you can see is that the rate ranges actually from about 20 to 80%, simply based on this genetic background alone. So what we have in terms of the state-of-the-art genome interpretation is if somebody gives me their DNA, at least in this study, if you have no monogenic bad mutation and a low polygenic score, we think your chance of developing heart disease in this study was only about 4%. But if you had the bad monogenic mutation and a high polygenic score, it was much higher, like 78%. And so this is what we consider the genetic double whammy. So when we think about polygenic scoring, it's really emerged, and we've done a number of studies and some others around the world, but it's emerged as a quantitative measure of inherited risk that looks at genetic variation across the whole system. It distills that inherited risk into a single number. It's available from birth. So the idea here is that we can give people a decades-long head start to be able to overcome this inherited risk. Now, the risk prediction actually exceeds that of traditional risk factors, things like blood pressure, cholesterol, or a C-reactive protein. Even when we look in our own hospital system, these high polygenic score individuals are currently flying under the radar within our practice. And it's up to 20 times as common as these rare familial hypercholesterolemia variants. Even for those who have one, this polygenic score modifies the risk in an important way. Lastly, what's most exciting is that from a single test, the scores can actually be measured for a whole range of preventable diseases. So simply by looking at someone's DNA, you can change the weights and calculate your genetic risk for atrial fibrillation, which is an irregular heartbeat, diabetes, inflammatory bowel disease, or breast cancer, almost any disease. And again, what I'm showing you here is that on the x-axis, the horizontal part is the percentile of the polygenic score, and the vertical is the chance that individuals develop disease by middle age. And what you can see is that in every case, there was a striking gradient across these percentile dots. And if you look at the extreme tails of the distribution, you're able to find people with 3, 4, even 5-fold increased risk based on common genetic variation alone. So, at our own hospital here in Boston, we said, well, we actually think this is an opportunity to put some of this into clinical practice. And so a couple of years ago, I founded a preventive genomics clinic. The idea here is to use genetic information to better understand, predict, and prevent disease. And to do this, we felt like we needed a totally new clinical infrastructure. And so what do we do? Well, one common situation is we guide people who are asymptomatic, meaning they're healthy, but they have a pathogenic or bad disease variant. And they might have gotten this from 23andMe or some other research study. And we said, okay, well, how can we work with you to overcome this inherited risk via tailored screening or prevention program? So some people come to us, but we also feel like we want to go out and find these people who are flying under the radar. And so we actually, in a collaboration with IBM Research, are performing genetic testing in 60,000 people from our hospital who volunteered to be part of a biobank study to find the 1 or 2% who have these rare, very bad high-risk variants and bring them into our clinic to try to help them. We also spend a lot of time discussing genetic testing, people who have symptoms of a disease or a strong family history. And here what we have found is that almost all of the tests we ordered have been covered by insurance. And the reason for that is that genetic testing, even if you go by the current guidelines, is highly underutilized within clinical practice, even at a hospital like Mass General in Boston. Lastly, we think it's important to be able to interpret the genome for those who are curious or concerned. And any of you who are able to come to Massachusetts, we're always happy to see you. We will see you in our clinic to do this. But really, we would say if someone hands me their DNA, they may want to understand what their inherited risk for heart disease actually is. And so a little under a year ago, we actually launched the first state-of-the-art genomic interpretation for coronary disease. It looks at both the, it's a collaboration with Color Health, a company in the Bay Area, but it looks at both the single familial hypercholesterolemia mutations that can be very high risk, but also this polygenic score. So it really puts you from the time you're born to any of these 200 dots. And these 200 dots, your risk might range from 4 to 78%. And based on that, we try to help you figure out what additional management we can do. And so the test costs $249 because it covers actually cancer and cardiovascular disease and actually pharmacogenetics as well. But we have pilot funding to offset the cost for the first 100 patients. And as of now, this new polygenic test is actually not covered by most insurance plans. But the first patient we saw was a 49-year-old man, and he had a heart attack, but no traditional risk factors. And here the question was quite simple. Why did this happen to me? Secondly, we had a woman was a 30-year-old woman who had a very strong family history and a mildly increased cholesterol. Now, what we know is that our risk factors and our risk models actually aren't really even supposed to be used at age under 40 years. And imaging tests like calcium, almost no one has developed any by the time people have reached 30. So there's a real need in these young patients to find the highest risk individuals. So she was looking for guidance saying, should I actually start a medication? So based on the 60 patients or so we've seen so far over the last few months, we've started to offer tailored clinical management. In some cases, that's led us to really recommend statin initiation or increasing the dose. We sometimes recommend additional testing like coronary artery calcium or lipoprotein A, which is particularly an issue in South Asians, as you heard. And then I think recommitment to lifestyle measures and really trying to counsel patients, especially based on their specific ethnic background, or referral to a nutritionist, I think we found to be quite helpful. And at least in the study, about 94% of the participants reported learning very valuable information from better understanding their genetics. So patients really like to have this information at hand. So this data was based on a predictor that works across all ancestries, but we set out also to say, could we actually for the first time try to build a genetic predictor specifically for a South Asian population? And this is something that hadn't been done before. Now, our hands were a little bit tied because South Asians are the most underrepresented population in the world. So South Asians represent 23% of the global population. But what you can see here on the horizontal axis is time, 2006 to 2020. And on the y-axis is just how many people were part of these genetic association studies. And what you can see is that the blue part is the European ancestry individuals. Those are the majority of individuals studied today. But look at the tiny little red sliver. That's the South Asian population. And it isn't really improving over time, where only 1% of genetic studies actually include individuals of South Asian ancestry. So this is a major limitation in studies today. So despite that, we said, okay, well, let's at least try to prove the principle. So we made a genetic predictor, again, of 6 million variants. We found 3,000 participants in India, 1,800 with heart disease, 1,100 who were healthy. And we made a pipeline to calculate polygenic scores, taking individuals' genetic ancestry into account using computational algorithms. And this is particularly important in South Asians because we're so genetically and ancestrally very diverse. So we were able to put people into 5 groups according to their polygenic score after we adjusted for their ancestry. And what you can see here is that the score actually worked quite well, that there was if you look at the top 20% versus the bottom 20%, there was about a quadrupling of risk that's observed. So this, I think, was, again, very important proof of principle that the predictor works, but we're very confident we can do even better. And this is a major focus for my lab, actually, for this year and beyond, as part of a large NIH-sponsored consortium. And so we're doing things like bringing the world's data together from many, many thousands of individuals with genetic and clinical data. We're using new statistical techniques. So saying, well, some things may vary according to ancestry in terms of our genetics, but others do not. So whether a variant is affecting a protein of a region or affecting the gene expression, those annotations and these functional parameters in the DNA are actually stable across ancestries. So trying to take advantage of some of those things using new algorithms to, again, improve the transferability of how we can borrow from related ancestries and related traits to really build the best possible genetic predictor for these individuals. So I think that there's this understanding of the increased risk of cardiovascular disease in South Asia remains a very important public health opportunity. I overall was very pleased to see that the American Heart Association and College of Cardiology recognized this increased risk as the only ethnicity to be a risk-enhancing factor in our current guidelines. But I think that's just the start. And you see that South Asians are more than double the risk, but it's not captured at all in clinical risk tools. I mentioned a few factors like diabetes and lipoprotein A and where we store our fat that may be playing a role, but I think there's more to be understood. Genetics has an important factor in terms of cardiovascular disease, and we saw that at least in a proof of principle study, but we really need to bring the worlds together, data together in best statistical genetics minds to try to move that forward. And lastly, I think preventive genomics is coming quickly, and in fact, it's already here at our hospital at Mass General, which now includes, it's a clinical test, the state-of-the-art genome interpretation, nothing research about it. We ordered as a clinical test, put it in the record, and really try to help our patients based on a tailored screening intervention to overcome any inherited risk that's identified. So thank you very much. And this is just a fantastic session, and I hope we have a bit of time for some questions.
Thank you, Amit. Really appreciate such a wonderful talk, and as the protocol, Brahma and I will be kind of asking a few questions, and I think I'll start this time just to ask a very quick question, which might be for both of you, whoever can answer. This is a kind of a question which is asked about dietary risk factors. Basically, again, like I said, I'll be asking the non-cardiology questions. I'll let Brahma ask the cardiology questions. So this one is about, hey, like dietary risk factors. I mean, rice versus wheat versus coconut. Why is Mediterranean diet always touted as being the heart healthy thing? A little bit on that, if you can touch on, and then I'll let Brahma ask. Please unmute yourself, Dr. Enes.
Okay, can you hear me now?
Yes.
Yes, yes.
Diet has been my favorite subject for the last 20 or 30 years. There is a lot of controversies on the diet, especially in India. And an important factor, in the last 20 years, cholesterol LDL level in the US came down by 20 points. This was more than expected. And they found out that was related to banning of trans fat by the FDA in the US. And we saw LDL coming down dramatically over and above from lifestyle and statin medications. Now, for Indians, and we have only 4 million or so in US, but close to 1.4 billion are in India. This is a very, very major issue. The Vanaspati is from 10 to 40% trans fat. And the government has not even agreed to define what is, here it is, not even 1% of the calories is allowed, whereas 20 to 30, 40%. Now, there is controversy about saturated fat, but we have many, many, many scientific bodies. World Health Organization, World Heart Federation, American College of Cardiology, American Heart Association, European Heart Association, European College of Cardiology, European Society of Atherosclerosis, they all recommend lowering the saturated fat as the key ingredient in dietary modification to prevent heart disease. So, but there are a few people opposing it, and some studies show. So my opinion is that trans fat and saturated fats are extremely harmful, and we have a big problem. The other issue is that fruits and vegetables is considered a surrogate for healthy diet. And the Indians do not consider fruits or vegetable as food. This is something on the side. Food is chapati and paratha and upma, something. So we don't think fruits and vegetables. Now, by any chance, if you are using vegetables, it's already deep fried for 2 hours before you consume it. So our deep frying make the food rich in trans fat and destroy all the nutrients. So other thing is that in vegetarians worldwide have half the rate of heart disease. A singular exception is Indians and South Asians. And why is that? It's the vegetarians have lower risk of heart disease, not because they don't eat meat, but because of what they eat. They eat chicken, fish, fruits, vegetables, nuts, all the healthy foods. Whereas in India and in Indians, okay, both vegetarians and non-vegetarians eat all the unhealthy food, no special preference for any healthy food, and non-vegetarians consume an ounce or 2 of chicken. So really, all Indians can be considered vegetarian when compared to Westerners, where in the US, the average consumption of meat is 12 to 13 ounces a day, whereas it's 12 to 13 ounces a month for Western, for Indian non-vegetarians. So
Great.
there are a lot of yeah. So there's a lot of information on the diet, and if you want to know more about it, you can go to my website caddyresearch.org, and there is an entire PDF available: prudent diet and preventive nutrition from pediatrics to geriatrics, for current knowledge and practical recommendations, just about everything. And another document you can read will be Dietary Guidelines for Americans. They're revised every 5 years, and 2020 Dietary Guidelines will be another source, but it won't address much of the South Asian diet. My paper does address, and my website also has about 20 chapters on diet.
Thank you. Thank you, Dr. Enes. I have couple of questions for Dr. Amit Khera. There are 3-4 questions, but I would lump them together. So, Amit, now when we take a family history, you think that is reliable enough, or you think there's incremental value for polygenic score? And also, in the same breath, I want to ask you, like we always get these commercials from 23andMe. Do you provide something extra, or you think that is equivalent to your risk prediction?
Yeah, so family history on average, we know about is associated with about a doubling of risk. So if you have if your parent was affected by heart disease, your risk is about double. And so it's very useful in that way. But one of the things that's interesting is it actually doesn't actually track that closely with the genetics. And so if you have a strong family history, it could be shared genetics, or it could be shared jalebi, and you actually can't tell. And so it doesn't actually track that closely with the actual genetics. So we found, even when you look at people with family history, without family history, actually quantifying that those genetics actually can be quite useful.
Okay, how about the comparison with the online, 23andMe or the genetic sampling tests? Do they give any information?
So so it's important to think about like genetic testing that's done for recreational purposes versus genetic testing that's done for medical purposes. And so the technology may be similar. So the 23andMe genetic array, it can actually be used to calculate these polygenic scores, but it's mostly useful for things like checking your ancestry and kind of recreational purposes. But then there are other types of tests that are being that are available that are clinical and genetic tests designed more to go into a medical record and pass all of the CLIA, which is the lab regulatory environment. So 23andMe, I know, is very interested in moving eventually to a more of a medical model. At the moment, I think it's more recreational genomics.
So one more follow-up question. We had the Professor Alka, Kanaya here. She was talking about you being also joining her in masala studies, so we can be more specific. Do you have any insights from that? Have you done any studies on the masala cohort?
So Dr. Kanaya in San Francisco has really led the development of that study. But one of the things that's exciting is we're going to be, she's going to be able to get genetic data now for that study. And so, we're planning on sharing some of our genetic scores and research to try to apply that to the masala study to see what can be understood. Another area of interest in my group is actually quantifying body fat distribution. And so taking a MRI or DEXA image and actually, trying to come up with more sophisticated ways than what's been done before to really quantify that body fat distribution. And so I think masala has some imaging. We have a machine learning team at our institute, and one option would be for us to try to use that existing data to try to come up with new insights to go beyond what's been done previously to understand fat distribution, because it does seem like that's playing a very important role.
So one last question from me. We know your mentor. He's from Pittsburgh, Sekar Ketisaran, who invented and founded this worm company, biogenomics company, which is making tons of money, and he is dedicated to the genomics of the cardiovascular disease. Can you explain what he's doing? What kind of genes he's looking?
Yeah. So a real question is saying, can we use what we've learned from genetics to actually make a new medicine? And so, I led some work with him, and others have led work where we actually, usually when you think about genetics, you think about it doing something bad, like increasing your risk. But there are a few examples. We found very remarkable genetic mutations, genetic changes. They don't increase your risk, they decrease your risk, and they decrease your risk a lot. So much so that some people are born with mutations that it makes it almost impossible for them to get heart disease, even if they smoke, have a bad lifestyle, and so forth. So that's a very small part of the population. So could we somehow extend the protective properties of that mutation to the rest of the population? And what's been possible is the technology called genome editing. Yeah. So the idea here is to give a medicine. It would go in and it actually edits the DNA, edits the genetic code in people's livers, and it would change it would basically put that protective mutation in these people's livers. And as a result of that, their cholesterol would be very low for the rest of their life. They would never have to take in medicine again. And so it's really a one and done type of therapy. And so I think it's extremely promising at the current stage is that it's worked extremely well in mice and non-human primates, meaning monkeys, where one-time injection, they knock the monkeys' LDL down over 60% for over a year, and it appears to be very safe. But it's never been tested in humans, and so the company plans to start that in the first quarter of 2022. So I think it's several years away from being widely available, but the hope is that the first patients could be tested early next year.
Okay.
Great, thank you.
Go ahead.
So there are a couple of other questions, which again is for both of them, which we had left over. Basically, what is the data on the oxidized LDL and elevated triglycerides along with LPA? Number two, if the patient is diagnosed, let's say by age 10, would you be putting a kid on lifelong statin if there is a strong family history? And they see the other point they have raised is that is niacin better than statins on LPA? And if the patients are intolerant to statins, what are the options? And before you answer this question, I'd rather have everybody post their questions on the chat box. It'll be difficult for us to unmute other people who want to speak. So that way we can get everybody's questions. The other thing is that there are some questions which are follow-up questions on people who have answered. Dr. Ennis has answered. Dr. Ennis, if I could request you to directly answer them on the chat box, that would be helpful so that we can keep new questions to that. So having said that, I hope you remember those questions which I asked before, and please go ahead.
Amit, do you want to just repeat the questions and maybe which one we should focus on first?
Yes. So what is the data on oxidized LDL and elevated triglycerides along with LPA? That's one question. Why don't we address one question at a time?
Yeah, so LDL is as people mentioned, the bad cholesterol that goes into the vessel wall and contributes to plaque. And so when it's oxidized form, it is particularly problematic and accelerates the plaque a little bit faster. So I haven't necessarily found it that helpful to measure in clinical practice, but it's been very helpful from a scientific standpoint to understand that it's really the oxidized LDL that can be quite problematic. Now, the triglycerides is the fat in the circulation, and that is a second kind of axis of risk. One of the things that was quite exciting recently was the first study to show that a medicine could be used in people with high triglycerides to reduce risk. And that medicine was Vascepa, which is a very potent fish oil. And so, and it reduced risk by 30 or 40%, a lot. And so the important take home point there is it's not the fish oil that's over the counter. In fact, you have to take about 30 fish oil tablets from Whole Foods to really get the amount that was used in the study. So really need very potent, purified, high dose, high potency fish oil has been shown to be quite effective in people with the high triglycerides.
What is the name of the drug again? What was the name of that high produce?
It's Vascepa, Vascepa.
All right.
The brand name.
Thank you. So the next question about is that if you're diagnosed by age 10, especially if you've got a strong family history, would you put the patient or kid on statin all of his life?
To answer, unmute.
Go ahead, sir.
Okay. All of the audience, I recommend reading the integrated guidelines for dyslipidemia management in children. This is the cholesterol guideline specifically for the children. And after extensive review, after 20 years, there was a previous report, then the second report came in, I believe, in 2012. They have recommended that if the LDL level is sufficiently high, that's about 160 for children, and the statin therapy can be used. And once you use statin therapy, it's usually for the rest of the life. I would modify that. In addition, I will check their lipoprotein little a also. And you can check lipoprotein little a as young as 10. And before I even go backwards, current US guidelines, dyslipidemia management calls for measuring all children for dyslipidemia between age 9 and 11. And again, between 15 and 7. So the children will get 2 opportunities to have the lipid panels measured and start, depending upon the level, start aggressive lifestyle modification, basically the life symbol 7 for Indians. And you wait until the age 10, even if you have family history, unless the level is very high. Then you can use statin, and there is nothing wrong. There is no safer medication than statin, used billions and billions of prescriptions written, and there is nothing wrong in you lifelong. And otherwise, people don't realize that if you don't take statin early, life may not be long.
So follow-up question on that is that if they cannot tolerate statins, what then? Or is niacin better for reducing LPA?
Niacin, lipid clinics use, I used to use a lot, but I cannot get it. None of my patients can get it because of the outcome trials are, there is no outcome trial done with niacin, but niacin trials all failed. As a result, insurance does not cover, and the drugs companies do not store, so that unless you are running a lipid clinic, large lipid clinic, forget about the niacin, it's not available. And in that point of view, no one should use non-prescription niacin. That is bad. You should not use non-prescription niacin. Now, those who cannot tolerate statin, we have many other options available, that especially for women in the childbearing age, and they are not sure about the pregnancy issues. There is something called Welchol, W-E-L-C-H oil. It's a resin, it's a modified resin, and can lower the LDL by 25-35%. But you have to take either 6 big horse pill, or you have to take 6 packets of this medication. It's much cumbersome, and it's also expensive. Then ezetimibe is a medication which doesn't have much side effect, so it cannot tolerate. Actually, about 80% of the patients I see in my lipid clinic are people who cannot tolerate statin. 95% of them can tolerate statin in my clinic or in my practice.
So let me ask the last question to Dr. Khera. Dr. Khera, any role for homocysteine or C-reactive protein in this age of calcium scoring and genomic scoring? Anything left for them?
So homocysteine and C-reactive protein are both, measures of inflammation. And what we know is that cholesterol is kind of starts the process of a plaque, but it's really inflammation. The vessels get quite angry, and that's what really accelerates the plaque development. So homocysteine and actually C-reactive protein probably is a little bit better, can be a pretty useful marker of inflammation. I do use it in my clinical practice, especially if people are on the fence. If they say, well, I don't know if I want to take a statin or a medicine, and it can be used as a tiebreaker, because we know that people who have high C-reactive protein benefit from some of these preventive medications even more. So I do think that even now, I do find it, not my first line test, but for people who are on the fence on medications, I find it useful. And then second, I will say that, the cholesterol treatments have become quite good, but the rates of heart disease remain very high. And so I think there is a question that of what's coming next. And there are a number of different anti-inflammatory therapies that are looking quite promising to be used in clinical practice to help, complement cholesterol lowering. And so as that happens more and more, I think we'll be measuring inflammation more and more as well.
Thank you.
Well, thank you very much. We're almost at the end of this. I just have two personal questions. Just very quickly, I take a fish oil a day Or so should I not be taking it? I mean, is it not beneficial at all? That's a question for Dr. Amit Khera, please.
I don't recommend people take the over-the-counter fish oil. I think if folks are inclined to do it, I don't think it's likely to be harmful. But number one, they're not regulated. It's very difficult to know actually what's in them. If you go batch to batch, the variability is actually very high. So many of my patients, if they're on fish oil, I say, well, why don't we switch that out for an even smaller pill like a statin, which has been so well studied, so highly regulated, so safe, cheap, and effective at preventing heart disease. If you're willing to take a pill a day, I think in many cases there may be something that's more effective. So in general, I basically never recommend people to start it. If folks are on it, I don't think there's a big downside, but I also think it could be swapped out for something more effective.
Thank you. And one last question for Dr. Enos. I think you'll be able to answer this in a little humorous way. I always have this discussion, let's say, / argument about having a glass or two of red wine every day for being heart healthy, and she doesn't believe in that. Can you rest the case?
Wine is supposed to be good. Any alcohol in modest amount is heart healthy. Some people prefer white, some people prefer red, but overall, alcohol starts small dose and increase to high dose, and it become alcoholic and issues. So there is a big problem with a lot of death from alcoholism. Drunken driving is related to. So if you enjoy the wine and if you can limit to 5 ounces, I think that's a good thing to do. It help you relax and do it with dinner.
Okay, great. Thank you. Well, thanks. It was before I do the vote of thanks, I'd like to ask our president, Dr. Anupama Gupta-Mukula, to please come and present plaques to the speakers and the moderators.
Thank you. Thank you, Amit, and thank you, Dr. Brahma Sharma, for bringing such outstanding speakers today. It was very interesting to listen to both of you, Dr. Enos and Dr. Amit Khera, and learned so many things. A common problem on the ground. I'm a person on the ground. I don't know the research part of it, but I know this situation, this condition is really bad. But when I do a screening at the health camps and all, I tell them, go get your calcium coronary score done. But the answer I get is this covered by the insurance? What if the insurance doesn't pay me? They're not ready to spend $100 to go get this test done. So how am I going to educate all these? It's such a bad thing right now in the community, so I feel very bad for them, like they're looking for the insurance rather than curious to go get that test done. So me and my husband went and got the test done. So mine is 0 and my husband has 300 score. So he went into lifestyle modification. He went to the lifestyle medicine specialist. 3 months, unbelievably, all his numbers went down. Cholesterol, you name it, everything. So that changed me, that I think lifestyle modification is something I think we need to advocate for our communities. So that's what my take home point today. Okay, so Vijaya, are you ready? Hi, Vijaya.
I would just say thank you very much for having me. And I totally agree. The calcium, the cost can be an important barrier. It is available as low as $50 in some areas, but in Boston, I think it's around 200 or 150. But I will say that that's changing rapidly. And with the new guidelines, I think it's going to be covered more and more by insurance in coming years. So please stay tuned.
I think we should push for these 2 tests, lipoprotein little a and coronary calcium score test, to be covered by the insurance. So our guys will go and get those tests done. Our primary care physicians can prescribe those tests and get them done by the insurance carriers. I think that's where I think we should bring some kind of a policy change, or in the healthcare reforms. I think we should focus on those things. rather than just advocating, hey, you have this high risk, nothing will change. So I think the work should be done at that level as well. And I just want to appreciate Dr. Ines for your outstanding contributions to cardiology. And we welcome you as member of RP Distinguished Speakers Club. And this is from the entire RP community. And next, Dr. Amit Khera. Thank you so much for the outstanding talk and talking more about the genetics and how badly we are as South Asians. And thank you for your contributions to cardiology. And we welcome you as a member of RP Distinguished Speakers Club. And thank you so much for your time today. Very precious Saturday. And thank you so much. And Amit and Dr. Brahma Sharma, thank you so much for moderating the session for us today. It's a very good attendance. Having 150 or 60 people attend on a Saturday is not that easy. These are all busy practicing physicians. So I want to thank each of you, RP members, for attending the CME session today. And RP is doing a lot for our members, and we have so many events coming up. So mine is a preventive part of it. I think the prevention is better than cure. So we started some healthcare screenings in India. We picked 75 villages in India, rural health preventive screening, where we are doing these tests, diabetes, hypertension, and all. So we are collecting some data through that, and hopefully we can put some kind of advocacy to the government of India based on those results, how bad the disease is in India versus in United States, how we are here. We have amenities, but rural India does not have those amenities. So, but I think education is the best way we can. So as an educational preventive thing, we started this 75 rural health villages, and any members can participate, sponsor a village. And also we have two great events coming up. One is the Global Health Summit, which is happening in January 5th to 7th in Hyderabad in India. And please register, attend. We have more sessions on healthcare, technology, telemedicine, and transformation. So this way we can do more preventive health education through these great platforms. And our theme is that. And then we have an annual convention in San Antonio, which is in June 23rd to 26th. And we welcome you all. It is 40 years of RP, and we are going to celebrate the 40th year of RP existence. So thank you so much, and have a lovely day. Thank you.
Thank you, Anupama. Please, before everybody goes, I just wanted to announce the next our next CME. As usual, it's always on the second Saturday, exactly the same time, 12 Central, and so that everybody can mark it on the calendar and that doesn't change and stuff like that. You can have a recurrent reminder for yourself. The next, again, like Anupama and I have been trying, we're trying to make this all talks kind of general audience specific. In other words, everybody will enjoy the talk rather than being specialty specific. The next talk, we've got fantastic speakers. They are gurus in their field. As all of us know, thanks to COVID, we all went to telemedicine platform, and it seems telemedicine is here to stay. It is going to continue, and we're going to see a lot of, the codes for the telemedicine codes are going to stay. So we have invited two top speakers, Dr. Manish Garg and Dr. Veronica Sikka, to talk about telemedicine framework in medical practice. They'll be covering all aspects, including what it entails, the legal implications, the medical legal implications, the telemedicine etiquette. It's very, very essential for every practicing physician, and we'll be sending you more and more reminders throughout the month. But please try to attend. And again, I thank the speakers and the moderator, and as usual, Anupama being top of your game, and we appreciate this very, very informative discussion. And I hope all of you can can join, and let's make this more and more popular. And by the way, after this, you will be getting a little email. Anyone who has registered will get an email, and you please fill that up so that you get your CME right away. So all the reason the CMEs are delayed, that some people are not filling those up. Once you fill that up, we'll try our best to get your CMEs within the week or two, so that you get the CMEs in your bag. So please remember to fill that questionnaire, which will come from API, and hopefully you guys all enjoy it. Have a great rest of the weekend.
Thank you. Thank you.
Thank you.